All right. Good afternoon, ladies and gentlemen and colleagues. So I'm very glad to see that today we have a full house. So it is my pleasure to introduce to you today this session dedicated to the support of respiratory health and more generally of human health in less privileged areas of the world. So without further ado, I would like to first introduce gladly Dr. Thomas Eichholz, Head of Global R&D in Chiesi, who will introduce this session. Thank you. Thomas, the floor is yours.
Thanks, Mario, and welcome again to the session. Very glad to see such a big audience for this special topic. It is my duty to give you a brief introduction to Chiesi, the company, before I hand over to what will be the series of interesting presentations on the real topic of today, but hopefully I'll provide some useful context for the rest of the presentation. So Chiesi is a mid-sized R&D-based pharmaceutical company based in Italy, out of Parma. And we have a significant effort that I will describe very briefly. So our mission is to be recognized as research-focused. So we are an R&D-based company. We wish to maintain a high-quality entrepreneurial team. And we have delivered significant products. So we have a reason to be proud of that. But today's topic is that one of our additional goals is to combine our commitment to results with integrity and operating in a socially and environmentally responsible manner. So that is one of the hallmarks of our company, is one of the strong backgrounds of the ownership, the family, Chiesi, that is behind the company. It expresses itself, amongst other things, in the presence of a foundation which focuses on work like the main topic for today's session. In R&D, we have a significant investment. We have more than 600 people directly active in R&D, 900 if you count the people in the different countries that are supporting pharmacovigilance and other efforts. We invested last year for the first time more than $500 million, and we had 42 active projects in R&D. We are present around the globe in R&D. Our headquarters are in Parma, but we're present in France, the US, China, Sweden, UK, and also Canada. Apologies to any Canadians for the mismatch in color. So we have a significant global team supporting our global R&D efforts. One of our areas of focus is in respiratory. There we are focused on asthma and COPD, the remaining areas of unmet medical need, but increasingly working on IPF and PAH, looking for disease-modifying treatments. We're also active in cough and non-cystic fibrosis bronchiectasis, with less emphasis on other respiratory diseases. That effort has resulted in the following pipeline, where we have very significant efforts in the areas of focus, asthma, COPD, IPF, and PAH, and less so in the others that I mentioned. It is this effort in this pipeline that has led us to gain a very strong understanding of the importance of accurate diagnosis has got in the prevention and treatment of chronic lung diseases, which is something now that through the work that will be described in the following presentations, we want to support the spread of in the rest of the world. Chiesi is not only a pharmaceutical company, but it's also a certified B Corp. To date, we are the largest global pharmaceutical group to be awarded this certification, which is a recognition of high social and environmental standards. And we're very pleased to see that earlier this year, Ferrer, one of the Spanish pharmaceutical companies, joined us also as a B Corp. So hopefully this will spread this way of working also in the pharma industry. It's an achievement to be proud of, but it has to be stressed that this is something that feels natural. Being present in the healthcare industry, working on healthcare science, is something that is very close to caring for others, so it feels a natural element of our work. So that's a quick introduction to who we are at Chiesi, what we do in R&D, and how that has led to our involvement in the project that you will hear of in the next presentation. So with that, I hand back to Mario, and you'll hear more from our next speakers. Thank you.
Thank you very much, Thomas. And now it's, again, my sheer pleasure to introduce Dr. Robert Levy. He is our Oh, I'm sorry. My bad. Sorry, Robert. Now we have, after Thomas, we have a remote intervention by Maria Paola Chiesi, the president of the Chiesi Foundation, that now should be already connected with us. And I leave the floor to Maria Paola for her introduction. Thank you.
We haven't put you on top of the. Oh, there we go. Oh, where's the? Oh. She should be able to.
Okay. Hi, good morning. I hope you can hear me well.
Yes, we can hear you.
Okay. Thank you, Mario. Ladies and gentlemen, distinguished professors, dear colleagues, good morning. I am honored to be here with you today, even if virtually, at this symposium to introduce the work done by Chiesi Foundation and its partners to address one of the challenges of global health. As we know, and how it is confirmed by the WHO, non-communicable diseases are collectively responsible for almost 70% of all deaths worldwide, and almost 3/4 of these occur in low and middle-income countries. The relevance of non-communicable diseases is also recognized as a major global challenge in the United Nations 2030 Agenda for Sustainable Development that sets the goal of reducing related premature deaths by 1/3 by 2030 through prevention and treatment. In particular, if we look at chronic respiratory diseases, they account for 4.1 million deaths, with COPD and asthma being the third leading cause of death. So tackling such complex health challenges require a global approach and a global commitment. Both global and local partnerships, innovative approaches, and listening and caring attitudes are needed to address the unmet medical needs of underserved populations in low and middle income countries. Since 2014, the Chiesi Foundation is at the forefront of fostering this global commitment together with several stakeholders. The Chiesi Foundation was created in 2005 as an expression of Chiesi Group corporate social responsibility, and for years it has been a grant-making foundation. But in 2014, we decided to increase our impact by leveraging on the deep relation we have with our parent company in terms of scientific knowledge and networking, for making a change in those settings where access to quality care is not guaranteed for all. In the same year, I had the opportunity to meet Professor Robert Levy and his team and get to know the work they were carrying out in the Georgetown Public Hospital in Guyana. I was very impressed by their commitment and by their courage in undertaking such a challenging pathway in a complex context, where there was no access to diagnosis and proper quality of care for patients affected by asthma and COPD. After this very inspiring meeting and the strategic reflection, Chiesi Foundation took a step forward, and we decided to actively support the GASP, Global Access to Spirometry project that we are discussing today, aiming at improving the management of chronic respiratory diseases, such as COPD and asthma, in low and middle-income countries. Over the past years, we have made available not only financial resources, but also expertise and connections that led to innovative and sustainable interventions for improving the lives of patients affected by chronic respiratory diseases and their families. So I take this opportunity to thank all the people who are working on the project from a clinical and managerial point of view. And a special thanks also to Dr. Mario Scuri, the chairman of this session, who is not only a valuable colleague at Chiesi Farmaceutici, but also the technical advisor of the GASP project at Chiesi Foundation. So based on the tangible results achieved by the team led by Professor Levy in Guyana, we realized that GASP could have a positive impact also in other settings. And for this reason, at the beginning of 2019, the Foundation supported the scaling up of the project in Peru, and more precisely in the city of Cusco, which is a completely different context, but shows similar challenges in the management of asthma and COPD. The journey that began in Guyana continues today in Peru and will continue tomorrow in other countries. We have demonstrated that GASP is a successful, replicable, and sustainable model that can be implemented even with limited resources if you have strong, determined, and mission-aligned partners at your side. So to conclude, the burden of chronic respiratory disease, especially in low and middle income countries, is still a huge global challenge, but this can and must be improved. And the Chiesi Foundation is determined to play a key role in making this change possible. We believe that through direct implementation of the GASP project and awareness raising among different stakeholders on the importance of acting together, we can improve the quality of life of patients and their families living in low and middle income countries. We hope that the GASP will become a reference model for other actors willing to reach the same goal and make the world breathe better. So before leaving the stage to Professor Levy, I would like to thank personally again all the people working on this project. Thank you.
Thank you very much, Maria Paula, for your very kind words. And now it's time for Dr. Levy to take the stage. Dr. Levy is a respiratory physician. He is currently a clinical professor of medicine at British Columbia University in Vancouver, and also the clinical lead of a transplant program at that university. Bob, the stage is yours.
Good afternoon. Can people hear me in the back okay? Am I clear? Excellent. Thank you. Delighted to see so many people here to share in this, I think, quite an exciting topic. As Mario mentioned, my background is actually in clinical physiology. I'm a respiratory physician. I'm head of the lung transplant program in Vancouver, Canada, but my true passion over the last couple of years has really been trying to explore how to share some of the riches we have in places where they don't have them. So I'll be talking to you about GASP, the Global Access to Spirometry Program. And one of the concepts I want to leave you with at the end of my presentation is really that health equity is more than equitable access to healthcare. It's the ability to fulfill our human potential in all aspects of health and well-being. So just to give you a sense of what we talk about equity and access to healthcare, this is some data that comes from the Federation of International Respiratory Societies. And it talks about disability life years, and it's measured per 100,000 individuals from all causes. So disability life years measures the total burden of disease, both from years of life lost due to premature death and years lived with a disability. So one DALY, or one disability adjusted life year, equals one lost year of healthy life, so not just human life, but healthy life. And obviously, there is quite a bit of disparity in the world, and no matter how you measure it, many countries are much more advantaged than other countries. So, obviously, I'm a lung specialist. initial interest was in looking at asthma and why asthma. So in the world, greater than 350 million people are thought to have asthma. And although in the West we tend to think of it as a disease that has impairment on quality of life and an economic cost, it actually results in over 500,000 deaths per year throughout the world. It's the commonest pediatric chronic disease and obviously more severe in non-affluent countries. It's a very common reason for preventable, emphasizing preventable hospital admissions among children, who represent about 30% of all hospitalizations. Data shows that about 12% of hospital readmissions within 180 days of discharge, making it one of the most common causes for readmission for a chronic condition. In the US, about 36% of asthmatics less than the age of 17 with asthma have reported being in the emergency department the previous year. Obviously, in non-affluent countries, underdiagnosis and undertreatment are common, access to spirometry and the like. And effective medicines may not be either available or affordable. So a huge target for us to take a look at. Switching the view to COPD, once again, some information from the Forum of International Respiratory Societies. It's the most prevalent non-communicable respiratory disease, about 300 million people worldwide, a stunning 4% of the world's population, third most common cause of death worldwide. In 2017, 3.2 million deaths from COPD, and that accounted to about 82% of deaths from chronic respiratory diseases. Obviously, it has a high prevalence and severity, huge economic cost. For example, in the European Union, the direct cost of COPD consumes about 6% of total healthcare spending, almost 40 billion euros, 56% of the total cost of treating respiratory disease. Once again, underdiagnosis and misdiagnosis are both common, especially in low-resource settings where access to basic effective care as well as diagnostics may be very limited. Okay, let's switch gears a little bit to take a look at the setting. We started off our project in Guyana. The reason we started in Guyana was it was a convenient thing. We had other teams and colleagues who were working there. It's an English-speaking country, and our team from Canada, we're going to be focusing mostly on education and self-management, so it made it a likely spot. You can see that Guyana, in the northeastern part of South America, is very proximate to the Caribbean, and in fact has strong associations with similar populations and a lot of trade through CARICOM with the Caribbean. It's the only English-speaking South American country. The ancestry is largely Indo-Guyanese and Afro-Guyanese. The spoken languages are English and Creole. It was related to Britain until 1966, when they gained independence, and as I mentioned, their trade agreement is predominantly with the Caribbean through CARICOM. Very limited tourism, and most of that is focused on ecotourism, bird watching, wildlife, outdoor adventure. The healthcare is comprised of both public and private sectors, and the Ministry of Public Health leads the public health sector, which functions as a universal healthcare system for all citizens and residents. Enough to be said that the public healthcare system has many, many shortcomings that unless residents have money to buy into the private system, there'll be a big gap. So the major city in Guyana is Georgetown. It's got a population of about 118,000. It's the capital and largest city. Here's Georgetown along the North Atlantic coast, and the neighboring countries are Venezuela to the west, Brazil to the south, and Suriname, or Dutch Guyana, to the east. This Suriname border is contested, and this western Venezuela border is contested, especially now that Exxon has identified very large oil reserves off the coast of Venezuela and Guyana. You can see from the photographs there, it's got a colonial feel to it and a Caribbean feel to it. The largest hospital in the country is the Georgetown Public Hospital. It's the major referral center in Guyana. It's about 750 beds. They often have about 900 patients in the hospital and 750 beds, so you can imagine some of the challenges. So why did we focus on asthma? Well, asthma was an easy target because if you look in the lower right, it's very high prevalence, and it's also very high impact if we can intervene on it. Very common, affecting more than 10% of the Guyanese population, as in all our nations, affecting infants to the elderly, exacerbations resulting in frequent visits to the emergency department, frequent hospitalizations, which we just don't see in the West anymore from asthma, deaths and impaired quality of life for patients and caregivers, a very high healthcare system costs, and a high societal cost due to absenteeism, loss of productivity. So when we first went there in 2013 and we looked at the scene for asthma, this is the emergency department. They've got 2 asthma rooms in the emergency department, and generally when you walk in, there are 8 or 10 patients, often kids who are on nebulizers getting their acute episodic care. Some will be admitted, but most of them will be treated with bronchodilators, given some doses, high-dose steroids, whatever else is around, theophylline, antihistamines, the like, and sent out without any care plan and without any maintenance medications. So certainly not a model that favors chronic disease management as largely adapted. And so this acute episodic care is really what we wanted to focus on because it's really based around education and self-management. There was no diagnostic spirometry, not a single spirometer in the country in 2013, or asthma education resources, and very limited access to maintenance medications. Inhaled corticosteroids were not common in the country at the time. So as I say, high prevalence, high impact, a good target for an intervention. It's not that people in Guyana, they've got excellent physicians and nurses and allied health there. It's not that they didn't know what to do, but it was putting it all together. And they do have Caribbean asthma management guidelines, which are largely similar to what we would be using GINA guidelines in our countries. We were very inspired by this study, which was conducted in Brazil in more rural communities by Susan Mercado and colleagues. And they had very, very high asthma hospitalization rates, as we did in Guyana, as well as very high death rates. And they created a very similar intervention. They called it the PROAR program. Basically what it was going out and doing diagnostic spirometry, confirming a diagnosis of asthma, and then giving out free canisters of medication. And you can see a nice relationship between the drop in hospitalization rate over a couple of years with the program versus the number of patients enrolled, and in the dark bars, the number of units of inhaled corticosteroids that were distributed. So this was inspiring, and when we actually went to the Guyana Ministry of Health saying, look, they did this next door, we can do it here, got a lot of buy-in. So at the start of the project, I must admit to having been somewhat naive and a little confused as the difference between global health and medical tourism. And our intent was to come back and really have an impact. We created partnerships with the major hospital and the Ministry of Health. We recognized that we were going to have to do a lot of training, so we had a team of respiratory physicians from my institution, as well as respiratory therapists, which don't exist in Guyana, doing on-site training, as well as when we were there doing virtual training and supervising interpretation of clinical symptoms, interpreting spirometries and the like, and bringing healthcare workers from Guyana for specialized training. We provided spirometry equipment and trained the staff, worked with the health authorities to introduce concrete guidelines that could be followed realistically with the resources available, provided education self-management. A lot of it would have to be contextualized to the Guyanese culture, and really a focus on creating sustainability, so recognizing we needed local champions and trainers and coaching them to bring them up to speed, and knowing that ultimately what we wanted to do was spread the model. So to break it down really simply, we had 3 tasks to do. One was to develop the capacity to do accurate diagnosis with spirometry. Number 2, develop strategies for patient education, family education, and self-management. And finally, work with the hospital and the Ministry of Health to assure there was access to appropriate medications. In fact, if you look at any chronic disease, these are the three principles, whether it's diabetes or chronic kidney disease. It's really accurate diagnosis, patient and family education, and appropriate therapy. We were not 100% sure we would be able to introduce spirometry in a fashion that would be found to be of high quality, considering the technical considerations and the importance on quality improvement. So we actually had a number of our colleagues do quite extensive studies assuring that over a 2-year period we could produce high quality spirometry, which would have met the standards for a laboratory in Canada or in the United States. Interestingly, and similar to what we'd see, these are all patients referred for asthma or COPD. 31% of the spirometries were normal, 33% were obstructive, 12% were restricted, and 6% were mixed. So obviously, spirometry was going to be important to make sure we got the right diagnosis. So we spent time working on asthma. It was an easy transition into COPD because the healthcare team there, largely allied health supported by local physicians, further education to be more specific to COPD. So overall, our general focus, once we introduced spirometry and the basic recommendations on management for long-term, the chronic disease, was to create sustainability, which came in handy because when COVID came in, it prevented travel for our team going back and forth. So we were fortunate at that point to have enough education and enough remote supervision to be able to maintain things. So it was important to identify champions, identifying trainers, and really coach them appropriately. And then in the more recent phase of the project, we've really focused on this decentralization. In North America, Western Europe, more wealthy countries, most of our asthmatic patients are not necessarily treated in acute care hospitals. They're treated either in the community or in community health centers. So that was our next focus. So in terms of coaching the trainer, as I mentioned, we did that on site. We provided virtual backup, especially for interpretation of spirometry. We sort of overread every study that went through. And we brought healthcare workers to Canada. They engaged in this course, which is Canadian Thoracic Society course to show validation of experience with education and spirometry performance. So back to the original project that we started in Georgetown Public Hospital. We were established in 2013. We established the spirometry, the training, medication access. Since that time, there have been over 20,000 people since 2013 who have been through the program. And you can see that the volumes have continued to increase. You may have noticed a little pandemic that slowed things down for most of us, but things are getting back up to speed at this point. In the last year and a half, we've been focusing on the decentralization piece. So Georgetown Hospital is our expert center where we provide spirometry education, respiratory MD and nurse are present, and institution of treatment. They get farmed out then to community health centers that are all within about an hour and a half of downtown Guyana, where they get education and follow-up and consolidation of treatment. Sometimes, if patients are not well managed, they end up getting referred back into the expert center. Here's a satellite shot of Georgetown. This is the Demerara River, famous for Demerara sugar, if anyone likes sweets. Here's a hospital. These are the community health centers that we're working with. We have limited data so far, but in the first couple of months at these health centers, we had doctors and nurses come in for training in the expert center. And now once a week, one of the physicians from the expert center goes out to each clinic to troubleshoot. And in blue are the number of visits, in orange the number of new patients. So they are actually seeing new patients and trying to manage them there, sometimes having to send them into the expert center. So beginning for that, there's about 120 patients who have now been successfully transitioned out of the acute care center into the community health centers where they belong, which is actually to be a real achievement. Some of these patients coming from some centers will travel for 6 hours to come in to get their spirometry and their education from around the country. Just show you a quick video from one of our patients who had a couple of things to say.
My name is Agnes. So what was your life like before you were diagnosed with asthma? All right, my life before I was diagnosed, I was living a normal life until one day I wake up and having a little itchy throat and start having a cough. And from that cough, I started to get short breath. I lasted like about 4 hours straight having this shortness of breath, so I ended up at the ER. And then I was here like for the entire day. At the hospital, they gave me different insulin, different inhaler series, but nothing worked. I ended up being hospitalized 7 days, and they reported to the pharmacy clinic. When I first started, I met with Nurse back then, and then I was still Dr. Bacchus. Thanks to her, I am pretty much okay because from 2017 to now, I'm down. Life is changed a lot. I'm breathing well. I used to have to climb every challenge and start relaxing and then continue. Now I'm able to walk up the step really without even holding on or even stopping. Experiencing like what the days before? Yes, actually, the last sick I went back was back in January. So now I'm pretty much critical that I used to be home every 2 to 3 weeks. I have 3 days, some 7 days, because it was disgusting because having to miss work and not only inconvenient people but my fellow colleagues.
And you're able to sleep comfortably through the night?
Yeah, definitely. I used to sleep with 2 pillows. Now I start sleeping with only one. I am able to at least have a little boundaries because at first I did not know about using the dog. I'm not putting much of. As I said, the peppermint oil would allow you to breathe a little better in the night when you're getting stuffy nose. And afterwards, I directed how to do a steam by Dr. Barker. She said you can do a little steam in the night. It make you feel better, yes. And I'm sleeping much better. And I'm not coughing that much in the evening any longer.
So you're using your rescue inhaler less?
Yes, I'm using that less because sometimes I used to got it. I have this inhaler that I got to take 2 in the morning, 2 in the afternoon. Sometimes I don't take that at all. For 2 to 3 days I go on without taking it. Unless I have an asthma attack or a shortness of breath.
Does your controlled inhaler?
Yeah.
You were told by the nurses to do that every day, right?
Yeah. So the other day when I came back from clinic, I realized that I'm feeling, to be honest, I feel really good.
So even though you're feeling good, that's because the asthma is controlled, right? You still continue your everyday inhaler, right? Your controlled inhaler, which is your fluticasone combined with your salbutamol.
Yeah.
2 puffs in the morning, 2 puffs in the evening. Remember to gargle and rinse. That's a must every day. Because if you don't, you're controlled now. But if you don't do that, gradually you're going to return to the symptoms. Alright? So you need to continue with the treatment.
Yes, sir.
For those of you who've been around for a while, that sounds like a page out of the textbook from the 1980s when we were managing asthma, when we were learning. Okay, we talked about, I'm just finishing up this piece here. We talked about importance of sustainability. The other component for global health is really creating models that can be transferable and utilized in other settings, albeit with adaptations. So what we're really focusing on is fostering transition of standard management for chronic respiratory diseases from acute specialty care in the hospital to primary care in community, as well as emphasizing patient-focused care close to home. And so our next concept and discussion was with the Chiesi Foundation was to see whether we could use a model like this, which we believe was creating sustainability and spread locally, to drop that into another locale where there were different needs, but albeit important needs. So we have a video from my colleague, Dr. Juan Carlos Rojas from Cusco in Peru, who unfortunately was not able to join us, but will be providing his lecture to you directly.
At the Regional Hospital Antonio Lorena of Cusco and Regional Consultant of the Tuberculosis Strategy in Peru. Today I am going to talk about the emerging of COPD in Cusco and in the Upper Andean area of Peru and the strategy that we are currently implementing to face this challenge. Let me start by giving you some background information. The city of Cusco was the most important urban center in the Tahuantinsuyo Empire, founded by the Inca Manco Cápac, famous for these palaces, temples, and squares. Today, the city has a population of over 4,000, most of whom still speak Quechua. The surviving language of the Inca Empire, according to the Peruvian Institute of Economics, EPE, in 2021, the poverty rate in Cusco fell from 31% to 26.0%, with a national average of 21.7%. Despite this, the Cusco districts are the poorest nationwide, with a poverty rate of 97.8% and an extreme poverty rate of over 80%. These high poverty rates result in a difficult access to quality health services, especially in rural communities, where health facilities are often not even present. In Peru, respiratory diseases are the leading cause of death, especially acute respiratory infections, ARIS, chronic respiratory diseases such as COPD, fibrosis, and persistent tubercular infection diseases. The most affected groups are also the most vulnerable, the young and the elderly. Looking at the causes of COPD, besides the common and known risk factors, the ones related to economic and cultural respects are particularly challenging and peculiar of this part of the world. Indeed, in the Andean area, the impact of environmental pollution and domestic of work exposure to biomass is rather relevant in the development of this progressive fatal inflammatory airway disease. According to the national census, more than 2 million families in the Andes region prepare their food by burning biomass, such as wood, dung, charcoal, and agricultural residues, sometimes plastic and waste, exposing themselves to the dangerous fumes produced by the stove in the middle of the house. The chronic exposure to this toxic emission is known to cause airway inflammation, eventually leading to COPD and other respiratory infections. Furthermore, the presence of combustion products with cancerogenic potential is an additional risk factor for the development of lung cancer. According to a study led by Dr. Aquina, professor in the Cayetano Heredia University, conducted to 3 Andean communities, biomass fumes exposure exceeded WHO recommended limited by 10 to 20 times. Women and children under the age of 14 are most at risk for domestic biomass exposure due to the amount of time they spend at home, while adult working-age men are exposed to biomass in different working sectors: mining, construction, woodworking and glass mining, polyester production, and tile firing. Unfortunately, in certain sectors, the lack of safety devices increases the risk of biomass exposure. Spirometry is therefore essential for this early diagnosis of chronic respiratory diseases and for preventing the worsening of the patient condition. However, access to diagnosis and pharmacological treatment is denied to most of the population due to the lack of universal health coverage and the high cost of private clinics. Moreover, the cost of treatment are not affordable for the majority of population. Indeed, the cost of monthly treatment is around 40 euros, corresponding to 15% of an average salary of 300 euros, which is the salary of a nurse. For these reasons, and due to the underestimation of symptoms and lack of knowledge and awareness of risk factors, many people waiver the pneumological examination with serious health consequences. Why focus our intervention in COPD? As I said at the beginning, it's the most common chronic disease in the local context. COPD exacerbation causes frequent visits to the emergency, hospitalization, and death, and adversely affect the health system and the whole society in economic and productive terms. Late diagnosis of the problem, underestimation by patients, and low confidence in treatment. Limited access to medicines and affordability of treatments. The GAS project focuses on 3 key objectives. 1. Accurate diagnosis with spirometry. 2. Patient education and self-management. 3. Raises awareness on risk factors and chronic respiratory diseases. The first step toward achieving the objectives was to establish a spirometry capacity. We set up a free consultation pulmonology service to make it accessible to the whole population of Cusco. The training of nursing in the correct execution of spirometry was also a crucial part. The training has also focused on performing spirometry in the most accessible way for patients for the most rural area and Quechua speakers. The first training took place in the Georgetown Hospital in Guyana. 2 healthcare workers from Peru were able to visit the spirometry lab in Guyana and learn from the local staff. A second training was then delivered in Cusco and extended to the doctors and nurses of the city. The patients identified are included in personalized education and respiratory rehabilitation program. As a first step towards effective prevention, we have been working hard on education awareness campaign. These are the results of the first 12 months of the GAS project. 1,250 patients were seen at the spirometry lab. 71 critical cases were identified and included in a respiratory education and rehabilitation program. 44 trained health care workers, doctors, and nurses on quality spirometry, performance, and patient management. 8 awareness campaigns were carried out in the rural communities, and 5 health education laboratories were carried out for a total of 250 people sensitized to the risk factors of chronic respiratory diseases. Then an explanatory video of a spirometry in Quechua language.
Samay mama, pokoy, 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 pokoy. Ya está, ña. Descansa, descansa, descansa.
While carrying out the project, we were able to identify the main challenges that patients and local health workers faced. One of the most significant problems is the lack of effective management of chronic respiratory disease, especially in terms of follow-up provided by healthcare personnel. Abandoning the patient to himself has a profound repercussion, not only for the quality of life of the patient and his family, but also for the social and economic system of the country. A patient who does not receive adequate follow-up is much more likely to return to the hospital with exacerbations of respiratory symptoms, be admitted to the emergency room, hospitalized, and these represent a high cost for the national health system. So, why there is no protocol for patient monitoring? The lack of personnel is one of the answers. Furthermore, technical and nursing staff do not receive adequate training for this purpose, and sometimes they do not know how to properly apply the technique to spirometry. In addition, to the environmental, geographical, and cultural barriers of the territory. One of the reasons why patients present acute exacerbation of respiratory symptoms is the high cost of a new generation prescription medicine, including novel combination inhalers, which are unfortunately not covered by the health insurance system. A good compliance to pharmacological treatment is strictly necessary to control the disease and stop its progress. Due to the current situation, this possibility is precluded for the majority of patients. The use of information and communication technologies, ICT, and particular telehealth, is changing the way healthcare systems operate and deliver services around the world. In Peru, given the type of territory, the state of the roads, the huge distances between the peripheral health facilities and the reference hospitals, and the lack of specialists in rural areas, telehealth is considered a priority by the Ministry of Health to improve access to quality specialist health services, which frequently has limitations for physical movement due also to socioeconomic and cultural reasons. The key elements to address the challenges previously described and to make a significant change in the local health system are: establish partnerships with public and private local institutions. In the health sector, moving to the mark of a conference with state entities, DIRESA, MINSA, is mandatory, especially if you want to change policy guidelines or make a difference in ministerial health policies. Create project sustainability through a capacity building program, knowledge dissemination, and a train-the-trainer strategy. To fill a gap in the health system, it is necessary to develop a model for easing the burden of saturated health system. Another important step is to spread the model, decentralizing the project activities and reaching out the most vulnerable population of the communities. For these reasons, the next step of the project are aimed at fostering optimal disease management for patients with chronic respiratory illnesses by developing a hub-and-spoke model. To achieve this goal, we will identify a hospital that can reach the level of expert center in the diagnosis and treatment for the patients, and various peripheral health centers that will be the satellite centers and will be dedicated to the education and follow-up of the patient with diseases already diagnosed. The Policlínico Santa Rita, the place where the GAS project Peru began, will play the role of mediator, coordinator, and trainer, and will be a point of guidance and reference for all patients, both critical and non-critical. Given the absence of updated and concrete data of the local epidemiological situation regarding chronic respiratory diseases, one of the project objectives will be to carry out a comprehensive and cutting-edge epidemiological study to support important changes in national health system to benefit chronic respiratory diseases patients. We are willing to work and advocating activity to introduce adequate treatments to be covered by the national health system, and to include respiratory diseases in the policy guidelines and strategies for the prevention and control of non-communicable diseases, and therefore in a ministerial policy agenda. Thank you for your kind attention.
I know Dr. Rojas would have loved to join us. Just a very brief moment to pull things together a little bit. You've heard about the gas project in Guyana, now successfully getting a foothold in Cusco in South America. And just to emphasize a couple of the points that came out in both presentations, really that health system improvement is dependent on strong partnerships. And unless those partnerships are there, we will not be able to create sustainability and spread. And really, the other issue is addressing a relevant system gap which is achievable. So we know for asthma and COPD, the majority of what we're trying to accomplish is not going to be accomplished by expensive interventions, but just by sharing knowledge and helping people create a chronic disease model like we use in our centers. The train the trainer or coach the trainer strategy is essential, creating capacity for spread, and this notion of getting patients out of the acute care sites into care in the community closer to home, and really reaching a broad population in need. Thank you.
Thank you very much, Bob. Thank you sincerely. And now some last few words from Massimo Salvadori. Massimo Salvadori is the head of responsible for Chiesi Foundation and is going to leave us this final message.
Thank you, Mario, for the introduction. Ladies and gentlemen, good afternoon. It's a real pleasure for me being here today, attending this very important Congress and having the opportunity to represent Chiesi Foundation work in the global health sector and in achieving the SDG number 3, Sustainable Development Goal number 3, ensuring healthy life and well-being for all at all ages, and to spend some final few words on the GASP future perspectives. First of all, let me start by thanking our partners, the Lung Association, represented here today by Professor Robert Levy, and Policlinico Santa Rita del Cusco, represented by Dr. Rojas, that we have seen on the screen. Those are the actors that are in the front line implementing GASP activities and ensuring basic healthcare services for people and patients in need that most of the time are excluded by their national healthcare system, or even worse, they don't have enough resources to afford those services. So my big thank goes to them and their teams on the ground. If I have learned one thing over my 15 years experience in the international cooperation context, is that partnerships are key to address the big challenges that we are currently facing. No single organization is in a position and able to solve those challenges alone. So partnerships are key to address those challenges. Within Chiesi Foundation, we have the capacity to talk with different actors at different levels to attract interested private and public donors interested in funding our intervention, and to creating multi-stakeholder partnership where local institutions, local governments, NGO, academia can sit down, discuss, and address those challenges. Within Chiesi Foundation, we also have the resources to fund long-lasting and innovative solutions, like it is the GASP model. So what we have seen today, and to me this represents the beauty of this model, is a project that is simple to implement, does not require a lot of funding, is scalable, and is also adaptable to the local context. For all those reasons, Chiesi Foundation is committed over the next few years to reinforce the implementation of the GASP in the country where we are, Guyana and Peru, to extend the scaling up the model in other similar contexts in Latin America, and also to export and testing the model in Africa, where Chiesi Foundation also works on the neonatal care sector, implementing the NEST, the Neonatal Essential Survival Technology model. We know that this is a very long journey that requires the implication, the commitment, and the participation of everybody. So my hope today, after this very inspiring session, is that many of you and your organization can join Chiesi Foundation cause in making this world breathe better. Thank you very much for your kind attention, and now give back the word to Mario Scuri for final conclusion. Thank you very much.
Okay, just a few words. First of all, again, it's been a real pleasure to see you all coming to attend this session. Thank you very much for participating. My heartfelt thanks and appreciation to all our speakers and to the Chiesi Foundation for allowing me to be a small part of it. So it's a lot of fun and really it's a privilege. Just my last few words, just should be on the screen. But we know that, I know that there is no Q&A session, but if you have any questions, we'll be glad to provide you any information about this program at our booth, A0.7, and then you can download with your cell phone the information about this program. So again, thank you very much for the speakers, for you, for your attendance, and Chiesi Foundation and Chiesi. Have and enjoy the rest of the Congress. Thanks.